All right, good afternoon, everyone. Hope all is well. My name is Dr. Aziz Satius. I chair the Department of Informatics and Health Data Science here at the University of Miami Miller School of Medicine. And welcome again to another installment of the Future of Health Data Innovation. We have a phenomenal speaker, but my colleague, Dr. Mairead Maloney, will share more about this presentation. But for those of you who are new to our department is one of the newest departments here at our School of Medicine, and it is really a credit and a tribute to our Dean Henry Ford for seeing the value of informatics and health data science. I oftentimes say those two are the new lingua franca that pervades all sectors, and particularly in healthcare, where it is really disrupting and transforming how we do research and how we provide practice and care. A little bit about our department. We like to say we are a department of the future, and it's not an empty boast. We are really matrixed. We have 5 verticals and several cross vertical initiatives. Our verticals include education, where we're trying to train the next generation of clinicians, scientists, and innovators steeped in innovation. We have a research vertical where we tackle issues on, clinical medical informatics, as well as computational and digital biology and population health informatics and digital health informatics. And then we have a third vertical that focuses on clinical care, trying to find ways in which we can bridge issues of access and ensuring that we provide the right treatment to the right person at the right time, undergirded by computational methods. And then we have a fourth vertical that focuses on venture, because we want to restore the rightful place of academic institutions as being engines of innovation. And then last but not least, which I think is very germane to today's conversation, is our service outreach policy and ethics vertical, where we believe that one of the most sacrosanct virtues that we have is to ensure that we do no harm and we ensure that we provide the best equitable and standard care. And we're tackling issues around the digital divide, as well as areas in which we can improve issues such as digital literacy and dexterity. And I know our speaker today will be talking about implications, but I will turn it over to my very, very wonderful and super brilliant colleague, Dr. Mairead Maloney. Mairead, thank you.
Thank you so much, Dr. Stashas. Before I get into introducing our absolutely incredible speaker, Mr. Alex Gonzalez is here to tell us a little bit about how you can earn CME credit. And Alex, I'll let you take it away. Thank you so much, Alex. I have the incredible pleasure of introducing today's speaker. Dr. Benjamin Collins is an assistant professor of clinical medicine in the Division of General Internal Medicine and Public Health, with a secondary appointment in the Department of Biomedical Informatics at Vanderbilt University Medical Center. He completed internal medicine residency at Temple University Hospital in Philadelphia, Pennsylvania, and also earned an MA degree in urban bioethics during residency with a thesis on a theory of socio-technical justice in healthcare. He then completed a clinical informatics fellowship at Oregon Health and Science University in Portland, Oregon, along with an MS degree in biomedical informatics, with a capstone project on developing an online training module for clinicians in healthcare. This work received the 2022 American Medical Informatics Association Academic Forum Best Paper Award. He also completed a research fellowship at Vanderbilt on ethical, legal, and social institutes of AI in healthcare. Also at Vanderbilt University Medical Center, he currently practices clinically as a hospitalist and works on research around ethics and equity in the context of clinical reasoning with AI in healthcare. We could not be more delighted to welcome Dr. Collins to our webinar series. And without further ado, I will let him take it away. Thank you so much for joining us.
Yeah, thank you for the introduction. Let me just share my screen here. All right, so everyone should be able to see the slides. All right, great. So I'll be speaking on a topic that I consider of high and increasing importance on the use of AI in healthcare and the potential for algorithmic bias, and more specifically on preparing clinicians to handle algorithmic bias related to AI in their practice. I have no conflicts to disclose. The learning objectives for this talk include to explain the importance of training clinicians on the use of AI in healthcare and the potential for algorithmic bias, analyze scientific literature to identify important content for clinicians to learn related to healthcare, AI, and algorithmic bias, and plan training for clinicians on topics of emerging importance related to the use of AI in healthcare. To do this, I'll go through first some background on AI and algorithm bias in healthcare, go through the methods I use to develop a module for teaching content on this topic to clinicians, go through some of the content from that process, lessons learned, and raise a few essential remaining questions. So over the past few years, AI in healthcare has undergone and still undergoing fast progress, leading to a wide variety of clinical and administrative uses, including but not limited to image analysis, risk prediction, decision support, patient monitoring, surgical planning, and documentation support. There's an opportunity for AI to bring many benefits, but they also bring the potential for harms. And there's significant uncertainty about how that balance of benefit and harm will play out, and significant uncertainty as well about how to use AI from a clinician standpoint to achieve the benefits and avoid or mitigate the harms. The novelty, uncertainty, and need to promote benefit while avoiding harm raises the need for training clinicians on AI, but the opportunities for direct training on AI is limited by the already overflowing amount of content that clinicians need to learn across levels from student to continuing education as a licensed clinician. And while it is still important to include in that content when possible, there may need to be additional pathways to training on this content, which is essential due to the potential for harm, and there are not many experts with sufficient experience to do this teaching. A complicating factor is the amount of learning that may be necessary to gain a solid grasp of AI in healthcare, and the lack of the determination on which content is important and which content may be excluded. There's been some work by Regina Russell at Vanderbilt and others who proposed a set of 6 competency domains for clinicians related to AI. The specific topic of focus today, algorithmic bias, fits within multiple of these domains. Unfortunately, won't be able to go through the domains in detail. The algorithmic bias relates to basic knowledge of AI, social and ethical implications, AI-enhanced clinical encounters, and evidence-based evaluation. With that, we will get more into the specific topic of algorithmic bias. To provide a foundation to work from, so bias here is a systematic deviation from the truth and the process that leads to such a deviation, as opposed to random error or noise. And algorithmic bias is an umbrella term for biases originating from the use of AI as a reflection of data input methods used for processing by the AI and human judgment. Some may define algorithmic bias more narrowly as only originating directly from the algorithm itself, but it can be difficult to distinguish what is specifically from the algorithm, as these biases are all very interrelated in how they emerge. Algorithmic bias can be observed in different layers of healthcare with disproportionate error rates across populations and risk predictions, false results in skin cancer detection, incorrect radiograph analysis, poor disproportionate allocation of resources. And those biases may be ingrained in a way that may not be easily detectable, especially at an individual level. So consider the image on the right here, which is AI generated, of what appears to be a Black male physician at a patient's bedside. While it may be straightforward to point out, so if you look at the stethoscope around the neck, you'll see that the earpieces are duplicated in this image. This is an error that's pretty straightforward to point out. But what may not be so straightforward is that without specific intent to generate a Black doctor or a doctor of color or female doctor, AI image generators predominantly produce images of white male doctors. This sort of bias can be embedded in different ways across other sorts of AI systems in ways that you cannot just look like. It's not an image that you can just look at and determine that there's bias present. So we discussed the reasoning for training clinicians on AI, and the reasoning for algorithm bias specifically is overall similar. There's the increasing use of AI, the risk of harm presented by algorithm bias, and similarly it is unclear how to best train clinicians on algorithm bias. But can you get to a point where clinicians are able to recognize if algorithm bias is likely to be present and determine how to use AI systems to minimize bias passed into patient care, or when not to use the AI system? To look into this, I initially started with a literature search on PubMed of 5 years of content. I focused specifically on 5 preceding years to look at the then current technology. So I was really working on this in 2021. So from 2006, content from 2016 to 2021. And after identifying relevant articles, I reviewed the full articles to extract concepts related to algorithmic bias in healthcare, where concepts were pieces of knowledge grouped together with similar content. And then I went until saturation of information, then grouped those concepts further into related inductive themes. I then used the top 5 concepts as the focus of the module. Initially, I planned on using the top 10 concepts, but early feedback narrowed the scope some to allow for a reasonable amount of content in the module for the amount of time that participants would spend in the module. And some similar concepts were merged as possible to optimize the learning content. I also developed a set of recommendations centered on the included concepts, along with learning objectives to guide the module. And I ultimately developed the module from scratch using basic web programming, HTML, CSS, and JavaScript. I also developed a short series of case videos to allow participants to apply learn the concepts within the cases. And the cases were formed around real AI systems. And there was also opened a forum section for discussion on those cases. The module itself was hosted on GitHub, and there were also a pre and post module survey to allow for feedback. This process led to 886 instances of 141 concepts across 86 articles, with those concepts placed into 8 themes, which are listed here, from least frequent to most frequent. So research, function, background, beneficence, healthcare, harm, trust, and data. The most frequent theme data appeared 281 times, and it also had the most number of concepts within that theme. The top 5 concepts are shown here: bias data, explainability and transparency, limits of regulation, risk of harm, and transformation of healthcare. These concepts fit into the themes of data, trust, healthcare, and harm, which were notably the 4 most frequent themes. Biased data, the most frequent concept, appeared 49 times. Based on those results, I developed the learning objectives, recommendations, and the module content itself. So the learning objectives for the module were to recognize different forms of algorithmic bias in the use of AI for healthcare and the origins of those biases, deconstruct algorithmic bias in the use of AI for healthcare by thinking through example cases, and empathize with the importance of recognizing and addressing algorithmic bias in healthcare by exploring problems resulting from algorithmic bias with attention to the disproportionate impact on already marginalized populations. To facilitate learning and the application of the content to real problems, I developed the set of recommendations for clinicians based on the concepts. So recommendations are listed here. There were 9 of them. So first, determine who you can seek guidance from in your organization or using AI systems, and be sure to ask questions when they arise. Consider who was represented in the development of the system and their goals. Review how the system was approved and how it was monitored. Check the training data, determine how bias could have influenced the data, and if that bias was adjusted for. If the training data is not available, advocate to your organization and developers to know more about the system. If the system does not provide a level of certainty, adjust your level of trust in the system output accordingly. Think about the harm that could come from using the AI system and how likely that harm is to occur. Calibrate your trust in the system based on how much you know about it and the risk associated with using it. And determine how the system fits in the overall care of the patient and the larger healthcare system. The module itself was organized in this way, from providing instructions, an introduction, going through core terminology, basically a set of definitions to set a foundation for learning. The main concepts, which was the overview of the top 5 concepts from the literature review, examples of algorithmic bias, overview of the recommendations that I just listed, and then the cases for the participants to work through. So I selected the core terminology based on what I thought at the time clinicians would need to understand the module content and for a basis for algorithmic bias, AI. and provided definitions of these terms. So you'll notice that important terminology such as large language models and generative AI did not make the list at the time. So this was really just before the Chat GPT became big, and we'll get more into some of that later, but it is important to note that some of that was not here. So we'll now go through some of the module content for the main concepts. The first concept of bias data, the largest source of bias in AI algorithms. Bias data often originates from flaws in data collection. Despite the lack of quality in data collection, many people assume that AI is free of bias due to the use of a scientific process in its development. However, flaws in data collection can lead to over or under representation in data used to train the AI tool. Bias can also present in data sets that are too small or incomplete. Healthcare in particular has numerous potential sources of bias data. If, for example, you want to avoid using EHR records with missing data and only use complete data to train your algorithm, you would tend to have samples that's of patients that are older, sicker, and more likely female. Similarly, when performing data collection in the healthcare setting, the process is inherently biased to those who are able to afford getting healthcare services. And pre-existing social biases often implicitly contribute to the presence of bias in data. Social biases can influence the availability of data to be used, selection of variables to be represented, and other often difficult to recognize features of data. System drift as a reflection of how bias can accrue over a period of time due to changes in society, changes in goals for the AI system, and how the AI system is implemented. And similar to system drift, feedback loops can make data biased over time. In this case, the results of the AI system itself can cause changes in the data, which then change how the AI functions. And really the importance of bias data is in how this data influences the development of the AI algorithm in a problem often referred to as garbage in, garbage out, where essentially AI systems are only as good as the data on which they are trained. The next concept was transparency and explainability, for which I used the frame of black boxes, where the black box refers to a situation where an AI algorithm has learned to provide an output, but no one is able to really explain how the system derived the output. This can be problematic in terms of our inability to know if the output is correct and fair. This is especially an issue in healthcare, where the ability to explain is essential to maintain trust in the healthcare system. Furthermore, the ability for users of an AI system to understand how the output was achieved is often purposefully hindered by commercial entities, where developers want to keep proprietary tools unexamined. This means that tools in use to provide incorrect or unfair output without the user being able to determine that this is the case. And clearly, this can be an issue where AI tools are used to provide clinical care. Underlying the concept of explainability and transparency is the inclination to trust or not trust the use of AI in healthcare. For clinicians, there's a need to determine how much trust to place in an AI system, as well as for patients for patient-facing AI systems. Part of knowing how much the trust to place in the system is related to the transparency of the systems, such as the ability to audit how well the algorithm is performing. Systems could also report a level of certainty with which is providing an output rather than simply a binary output. And based on what is known about a system, a clinician needs to be able to calibrate their level of trust in the system, with the level of trust dependent on the context in which the system is used. For a high level of trust, the clinician may have high confidence in how well the AI system functions for the specific patient they are seeing, and have evidence for having that trust, such as information about AI having good performance for similar patients. But high trust is not always the goal, as that trust can also potentially be misplaced. For medium level of trust, the clinician may know that the AI works well in general, but not necessarily how well it would work for a specific patient. And then for low trust, there may be little information about the AI system, or there may be information that the system performs poorly. The third concept is limits to regulation of AI. To effectively use AI tools, clinicians should have some understanding of the regulation for those tools, and for understanding bias, specifically the limits of regulation. The legal response to new technology always lags behind the development of that technology. At the time of developing the module, the FDA had not addressed concerns regarding algorithmic bias in tools used for healthcare. While they have worked on updating their processes, this remains really not directly addressed. There's also still significant uncertainty about the liability related to development and use of AI systems. And as with other areas of healthcare, industry can exert a significant influence over the regulation of AI. The fourth concept was risk of harm. Or in general, the use of AI tools present a risk of bias, and that bias presents potential harm. Where bias is involved, it also means that risk of harm is often disproportionately distributed to marginalized populations. And this harm can arise really anywhere in the life cycle of an AI system, from the development of an AI system and deciding what to make an AI for, why, to the collection and use of data that informs their algorithm, to where and how the algorithm is deployed, as well as how it is evaluated. The most commonly referenced form of harm from algorithmic bias in the literature was racism and colorism. This goes back to the issue with biased data, where racial minorities are underrepresented in many studies, but it goes back even further in that the developers of AI algorithms are often not representative of minority populations. This influences the decisions made in the development process, especially where social factors are involved and may not receive enough attention. The final concept, transformation of healthcare, places the risk of algorithmic bias and the use of AI tools into context of how the healthcare system is changing and how the role of the clinician is changing alongside that. There's a clear paradigm shift occurring with the datafication and digitalization of healthcare, impacting what clinicians are expected to know and how they are expected to interact with their patients. Where each day, 750 quadrillion bytes of patient data is produced, which is far more than what human clinicians can work with, making AI algorithms increasingly useful in the healthcare workflow. And just a short description of the cases which I developed videos. So the first case is split into parts A and B, or an algorithm to predict severity of COVID-19 to guide not fully validated until after it was implemented. So I have the description in the middle column, and then on the right column, the questions that I posed for the forum. The second case was on disparities in knee osteoarthritis pain, with Black patients more likely to have severe arthritis or on standard radiographic measures, but more pain even when controlled for severity. And an AI was developed that decreased this disparity. This case was included to show a point on how intention for equity was important for how AI performs across populations. And the last case was on an AI developed using VA data to predict acute kidney injury over 48 hours. And since this data was predominantly male, the AI performed worse for female patients. And just to go over the feedback survey, so it really only got a few responses on the surveys, 9 pre-module responses, where participants reported really a low level of knowledge on algorithmic bias before the module. So on a scale of 0 to 10, where 10 is the most, mean of 2.75, a range of 1 to 7. And then for perceived importance of the topic, a mean of 6 with a range of 2 to 10. And I only had 3 post-module responses, but overall positive experiences, positive use of the system that was for the module. The importance of the topic post-module was 9.30. Again, just 3 responses, and not certain in terms of like who from the pre-module also completed the post-module. And then level of knowledge, 8.33, and effectiveness of the model format, mean of 9. So several lessons were learned. So from a utility standpoint, there needs to be more incentive for participation, even if it is, the topic is widely considered important, but at least CME credit or something to incentivize participation. The content needs to be focused. The shorter module may have more participation. So overall, in which I didn't note the length yet. So it was in total about an hour and a half of content, including the module itself and the cases. And there's a clear evidence of shared concern, ongoing uncertainty related to algorithmic bias in healthcare. And it really takes a collaborative effort to address, even on the training stage, where I would not again develop a full module on my own. And this work is originated from my master's degree work when I was at OHSU, which is a large part of why this was done mostly on my own. But in terms of getting the best content, the best quality, it is helpful to have multiple people involved. And the frequency of concepts from the literature search is not necessarily the most important for determining what content clinicians should be trained on. So say particularly the transformation of healthcare concept, while potentially helpful from a foundational background point, it's not necessarily as useful from a skill in using AI perspective. And there are also many intersections of related concepts that can guide content for training. So really, in terms of approaching training, no single method is necessarily optimal. The content that I used in the module here, I also developed other modules and have used that content in workshop, conference presentations and panels, grant rounds, and text related to the content. What I have not listed here is classroom lectures, or which I've read some articles about AI content being included in like medical school courses, but still very minimal, and not across, like, there are not many instances of that being reported in the literature. And I have not really spoken to anyone who has had the opportunity to teach this content or have had learning of this content within the classroom setting. So just a couple of remaining questions. So when to update, and this was one that I thought was important to bring up, particularly because of the shift into large language models. And so when I developed the module, that was right before the ChatGPT became big, before other large language model systems became more incorporated in different fields, including in healthcare. And AI continues to progress really even on a year-to-year basis. So how often should content for learning like this be updated? Because at this point, while the basis for the module is still relevant, there's other content that I think may be more relevant that should replace some of the content that was included. Then how well does the learning of this content translate to clinical practice with AI? This is an area that I think really needs study, because like we can't just spend our time teaching the content without knowing that it is having an impact on how AI is being used by clinicians. And then again, back to the large language models, how would that really affect the shape of algorithmic bias in healthcare, and how clinicians should think and learn about algorithmic bias? And with that, I thank you for your time for listening. I've listed some contact information. I've also listed the module website if you want to take a look at that. So again, I think that would really benefit from being updated at this point. But I will open for questions.
Thank you so much, Dr. Collins. That was a really, really engaging talk and so timely, could not be more timely and relevant. So I had a question that I'll kick off with. I see that there's another question in the chat as well. And then Dr. Stasios always has great questions. So while we're waiting on that, folks in the audience, feel free to please put your questions in the chat. And I'll just start with my pretty general question, which is, what are some of the ways you think we can encourage participation in learning about AI bias among clinicians and students who we know are, very, very busy, and certainly CME is one way, but just curious ways you think we can really encourage folks.
Yeah. So I think one avenue that has been brought up to me before was so like biostatistics is an area that's already within the learning curriculum for students, and a lot of AI is related to that type of content. So they could really have some merging of content there, particularly like examples or methodology, things like that. Um, but in terms of like getting experiences, so I think it would be helpful to include like clinical simulation scenarios, so that where they can get both the clinical experience, but also experience in terms of having used an AI system in part of the scenario. And then it can potentially debrief in terms of like, well, why did you use the AI system this way, or why did you interpret the output this way, in addition to their clinical learning from the simulation.
Dr. Collins, I have to tell you, I love that insight and suggestion. I actually remember some examples that were used in statistics class when I was a grad student still, of particularly showing how data can be used for ill intent, that has stuck with me to this day. So I love that idea. I think it's really powerful. Thank you. For the sake of time, I'll move on to the next question. Alex, did you want to read your question?
You can go ahead and read it, Dr. Mooney.
Okay. So what does the current landscape of AI tools that physicians interface look like a few years after this research? How common is bias in today's models? If it is common, can education be effective at addressing bias in an environment with easy access to biased model output?
Yeah, so good questions. So at the time of the developed module, it was AI was predominantly on like visual areas of healthcare, so radiology, pathology, dermatology. And while that's still the largest area that is being used in, there are a lot more opportunities for using it in non-visual fields as well. A large part of that was opened up by large language models, like with the potential for discussing with a chatbot the diagnosis for a patient. Like you can say, like, oh, I consider this. Is there something else that I should consider? Now, a lot of that is still not really approved for actual clinical care, but it's definitely moving a lot towards inclusion of other types of models at some level. And how common is bias in today's models? Really say it's still very common, not necessarily as significant. So like the cases that I included were AI systems from 6 to 8 years ago, and the recognition of those biases did lead to improvement in systems, particularly in terms of how they were developed. But the biases definitely still remain present, especially when there's not an intention. So AI is not neutral inherently. If you don't approach developing the AI system, using the AI system with the intention of equity in mind, there's going to be a tendency for AI to promote biases. And there's still a lot of work that does not have equity as part of the intention of the model.
Very beautifully stated. Absolutely. I think we have started to conceptualize AI as its own entity, but in fact, it is something that is developed and created by humans, and humans have biases, and we just can't take the bias out of the picture. So beautifully stated, Dr. Collins. Dr. Seixas, did you have questions?
Well, thank you. And those are great questions, Dr. Maloney and Dr. Collins. Thank you so much for a very thoughtful expose of how you've gone about operationalizing bias in algorithms, and how does that then lead to AI. So I just want to tip my hat to you. So kudos, and really looking forward to how your career evolves. I have several questions as Dr. Maloney, because she knows me oh so well. So I'm trying to figure out, which one do I lead with. But, I'm looking at the audience, and perhaps, you know, if you could just, I'm looking at the audience, and I'm trying to see how deep should we go or not. So I'm gonna just take it more at a surface level, if it's fine. So as you rightfully just pointed out, that algorithms and AI are really manifestations or products of 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 human creation, so to speak. And so, while we may call it bias, but it's really perspective, it's lens, it's context that pervades everything that we do, right? It's the lens. And obviously I'm not trying to say that it, we should not try to fix those issues, because the AI, as much as we want them to make that, as much as we want them to be agentic and to be human, like, they are not humans, right? They're not sentient beings. And so, I guess my question is, if you could just share with our group here, um, how do you define bias, right? How do we know what bias really is? And that's why I said I want to take it at a surface, level, because you can see bias in multiple ways, right? You see this now, many conversations going around, more so in the social sphere. And I don't want to get too, caught up in it, but even with what happened in BAFTA, where people are talking about this dialectic between intent and impact. And so if you could just say a little bit in terms of how do you, as an expert, define, bias? And one, what do we look for, as you rightfully pointed out, but how do we, like, yank it, from our operations? Obviously, the impact is the holy grail, but say a little bit more in terms of how you would define bias in algorithms.
Yeah, so really the first thing is differentiating statistical bias and social bias. So statistical bias is essentially going to be present no matter what in terms of how we operationalize and develop an AI system, because we want it to do something specific, so we have to bias it towards that
Perfect.
objective. But obviously, so the statistical bias can be positive or negative. Obviously, social bias is always going to be negative, and we want to mitigate that social bias. And part of the process of mitigating social bias is using statistical bias to our advantage in terms of how the output of the AI system is produced. So there's always, of course, going to be some level of random error that confounds our ability to measure bias. So we may have, particularly like at an individual case level, it gets really difficult, because you may have a patient who fits in one population and the result for them is inaccurate. Is it because they were in a specific population, or is it just based on probability that they happen to get a bad result from the AI system? And on one level, really impossible to say. And that's part of what makes the most difficult from the clinician perspective, because we want to be right for the patient all the time, but that's not going to happen. So how do we maximize that part is really the question. And AI systems can be very good at maximizing how often we are right, But the issue then becomes like if there's that social bias in the AI system, we can get a very high overall quality, but still have a bias where for certain people it may be almost always wrong, and being able to distinguish that.
I love that because I was hoping you were going to go there because, we had published a paper, I think 2, 3 years ago, with the American Academy of Sleep Medicine. And one of the things that we tried to do was to deconstruct the different forms of biases, because you're right. One way of looking at it, you can bifurcate it as, you may use it as, kind of statistical or technical or social. And I think there's so many different biases that I think really needs to be, greater ferreted out for us to understand, what's the genesis of those. And I think obviously we have a lot more control over the statistical biases, but as I think you rightfully pointed out, it's determining, the chicken or the egg, right? Are the statistical biases more so driven by the data biases because of the low representation of training models, right? Or is it because the statistical analytical tools that we use are really geared toward looking at more frequentist approaches, right? Which are normally distributed. And so for marginalized groups where they don't find sometimes themselves in the middle of, that normal distribution, then that inherently or statistical methods may be reproducing some type of bias as well. And I'm not trying to get too heady here, but I think, this is part of what we're trying to fully understand as a department as well, because, even math has some bias, even though they think it's pure math as well. You get what I'm saying? And so that's kind of where, I'd love to hear from you, particularly clinicians or researchers trying to figure out, they're doing their honest, they're doing their best, they're trying to collect data, and they have no intent of having a biased data set, right? And therefore, they have to look at, the different, sensors that they capture and all of that. So we can really, if we want to get into this game, and I don't mean game in a negative way, but just really get into bias, there's so many things that we can unfold, and I'd love to hear your thoughts. And I know that we're at time, but I could go on and on because I'm really loving this conversation.
Yeah, and just quickly, so since you mentioned math, so one of the like as curious people tend to think of math, the way that it was developed by humans, like the order of operations, like you don't necessarily have to do it's not inherent to math. It's something that humans came up with to standardize the way that things are done.
Yep.
That is a bias, but it's a one that tends to be helpful in terms of making sure that everyone does the same way, so that we can communicate better, really.
No, this is great. And Dr. Maloney and Alex, I don't want to take over, but this is fantastic. Dr. Collins, I think, from my side, I would love to continue the conversation, not right now, but hopefully you will see this as a home away from home for you, because I think these are some of the fundamental questions that in our very busy schedules, we don't get to really ask these types of questions. And unfortunately, my worry, and I think Dr. Maloney and our department believes this as well, that we can't just be passively accepting tools and not offer real solutions, not just pragmatic solutions, but methodological solutions as well to get at the root cause of these biases. So I really appreciate that. And I'll hand it over back to Dr. Maloney.
Thank you so much, Dr. Seixas. That was a really engaging conversation. We are unfortunately at time. Please do join us next month. But let's all give Dr. Collins a massive thanks for his time and his expertise. Such a delight, and I'll see you all next month. Thank you so much.
Great job, folks.